Hello, everyone, and welcome to our module on carbon dioxide. So carbon dioxide is a gas, and it's produced by cellular metabolism, which I talk about in detail in videos in the biochemistry section. And it's eliminated in the lungs via perfusion-limited gas exchange. I talk about this in the video on pulmonary circulation, but by perfusion-limited gas exchange, carbon dioxide diffuses into the alveoli, and then it's exhaled from the body. But then in this video, what we're going to do is talk a lot about how the carbon dioxide gets to the lungs so that it can be eliminated. And it travels from the tissues in our bodies where it's produced to the lungs via three mechanisms. Some of it is dissolved, some of it is bound to hemoglobin, and most of it gets converted to bicarbonate. And so we'll go through all three of these things in the next couple of slides. So the amount of dissolved carbon dioxide in our blood is determined by Henry's law, which you may remember from a chemistry or physics class. Henry's law says that the amount of dissolved carbon dioxide or any gas is equal to the partial pressure of that gas times its solubility in that liquid. And this turns out to be a very small amount of the total blood carbon dioxide. Only about 5% is dissolved in our blood and transported to the lungs that way. There's also a small amount of carbon dioxide transported to the lungs bound to hemoglobin. And when hemoglobin binds carbon dioxide, we call that structure carbaminohemoglobin. And this is a very small amount of the total carbon dioxide produced from metabolism. Only about 3% is transported bound to hemoglobin. And you should be aware that carbon dioxide binds to hemoglobin at a different site from oxygen. And when carbon dioxide does bind to hemoglobin, it alters the affinity of hemoglobin for oxygen. In the video on hemoglobin, I talk about right shifts of the oxygen dissociation curve. This is an example of one shown right here on the slide. So anytime carbon dioxide binds to hemoglobin, that promotes more oxygen release. So this means that carbon dioxide decreases the affinity of hemoglobin for oxygen. And hopefully this makes sense to you because carbon dioxide is produced in areas where there's a lot of metabolism going on. And that means those tissues, those areas need lots of oxygen. So anytime hemoglobin starts to bind carbon dioxide, it knows there's a lot of metabolism going on. And so it will decrease its affinity for oxygen and release more oxygen. And that's what is shown by this rightward shift here in this picture on the slide, which I talk about in detail in the video on hemoglobin. Okay, now let's talk about bicarbonate. So most of the carbon dioxide produced from cellular metabolism is converted into bicarbonate, about 90%. And then the bicarbonate is the carrier form of CO2 that travels to the lungs. Bicarbonate, in case you've forgotten, is HCO3 negative, and it's produced from carbon dioxide and water through this reaction shown at the bottom of the slide. And the enzyme that catalyzes this reaction is called carbonic anhydrase. It will convert carbon dioxide and water into H2CO3, which then breaks down into bicarbonate and protons, meaning acid. And you can find carbonic anhydrase in most cells in the body, including red blood cells. We'll talk more about this later. And as you see at the bottom of the slide, it converts carbon dioxide into HCO3 negative. And then the HCO3 will travel through the bloodstream to the lungs where it will be converted back into CO2, and then the CO2 can be exhaled from the body. So just to give you a clear picture of how all this occurs, on the left side of the slide here, I've shown an image that represents the tissues. On the right side of the slide, I've shown an image that represents the lungs. So in the tissues, cells are consuming oxygen and producing carbon dioxide. That carbon dioxide can diffuse into red blood cells where it's converted into bicarbonate, and then the bicarbonate is released into the plasma. So in the plasma, in the blood traveling through our veins back to the lungs, you find a very high level of bicarbonate. That's because it's the carrier form of carbon dioxide. Once blood reaches the lungs, the bicarbonate is converted back into carbon dioxide, and from there it is exhaled. And so if you look at this reaction at the top of the slide here, keep in mind that all these reactions are reversible. So in the tissues where there's lots of carbon dioxide, you're going to get lots of bicarbonate produced. But then when you get to the lungs, the carbon dioxide content is relatively low because carbon dioxide is being exhaled. That's going to drive the reaction back in this direction and reproduce that carbon dioxide in the lungs so it can be exhaled. So this equation at the top of the slide goes back and forth, goes one direction in the tissues, the opposite direction in the lungs, and that's how we transfer carbon dioxide through the body in the form of bicarbonate. So the red blood cells are very important for producing bicarbonate. Carbon dioxide can diffuse into red cells where there's carbonic anhydrase present that will convert it into bicarbonate. The bicarbonate can then leave the cell, but because bicarbonate is negatively charged, when it leaves the cell, something negatively charged has to come inside the cell to maintain electrical neutrality. You always have to have positive and negative charges balanced inside cells. So when the negatively charged bicarbonate leaves, what negatively charged ion enters the cell? Well, that's chloride. And this is a process called the chloride shift, described many decades ago by basic scientists. Chloride enters red blood cells after bicarbonate leaves in order to maintain electrical neutrality. This means that red cells have a very high chloride content in venous blood, because remember, in the venous blood, that's where there's lots of carbon dioxide around that's getting converted into bicarbonate. And so in terms of board exams and answering questions, you just want to remember that a high chloride content in red cells always means there's lots of CO2 around. That's what you're going to find in red cells after they've left the tissues when they're on their way to the lungs. Another thing to know about how red cells handle carbon dioxide and bicarbonate is that when red cells produce bicarbonate, they also produce protons, meaning acid. And so this could cause a dangerous fall in the pH inside of red cells unless it's buffered. And the way it's buffered is that hemoglobin can bind protons. Deoxyhemoglobin buffers or absorbs lots of the protons inside red cells. And we already talked briefly earlier in this video about how when CO2 is produced in tissues, this right shifts the hemoglobin-oxygen dissociation curve and produces more deoxyhemoglobin. And that's a good thing because it's going to make deoxyhemoglobin available to bind those protons and prevent the pH inside the red cells from falling. So a key point to understand is that anytime CO2 is being produced in tissues, that's going to lead to more deoxyhemoglobin inside red cells, and that's a good thing for preventing the H+ from reducing the pH. And so here's a cartoon that summarizes all the important things you want to remember about bicarbonate. So in the tissues, oxygen is consumed and carbon dioxide is produced. That carbon dioxide diffuses into red cells where it promotes the release of oxygen. In other words, it creates more deoxyhemoglobin. And this is a good thing to provide oxygen for metabolism. The carbonic anhydrase inside the red cells will convert the CO2 into bicarbonate. That bicarbonate will leave the red cell and enter the venous blood. So this is a high-yield thing to understand, but there's always lots of bicarbonate in venous blood on its way to the lungs, and that's because that bicarbonate is the carrier form of carbon dioxide. In exchange for releasing the negatively charged bicarbonate, red cells will take up chloride, and that's the chloride shift. And then we talked about how anytime bicarbonate gets produced, you also produce protons or acid, so there's a rise in red cell H+ whenever there's CO2 around, but luckily deoxyhemoglobin can buffer that so the pH doesn't fall. And then in the lungs, this whole process reverses. So in the lungs, oxygen is picked up by hemoglobin, so there's a fall in deoxyhemoglobin. That releases lots of these protons. That's going to bind with bicarbonate and drive the reaction this way. You also have relatively lower levels of CO2 in the lungs compared to the tissues. So this whole reaction is going to drive in the other direction. The CO2 is going to be recreated in the lungs, and then that can leave through exhalation. Okay, now we're going to talk about a couple of chemical phenomena around carbon dioxide handling in the body. And the first one we'll talk about is the Bohr effect. So as we've already seen, when CO2 is produced by metabolism, this generates protons inside red blood cells. The CO2 is converted to bicarbonate, and that's going to generate protons. And anytime you have more protons, the pH falls because protons are acid. So one key thing to know just in general here is that acid and low pH are indicators of metabolism, because anytime you see these things, you know there's lots of CO2 around inside the body. And so the Bohr effect basically says that protons in low pH trigger the release of oxygen by hemoglobin. And we've sort of already talked about this. We just didn't call it the Bohr effect, but we talked about how CO2 is one of the things that can shift the hemoglobin-oxygen dissociation curve to the right and cause the release of oxygen. And the reason CO2 is able to do this is through the production of protons and the lowering of pH. So the Bohr effect basically says that deoxyhemoglobin has a high affinity for protons, and we've already discussed this. This is one of the ways that acid levels are buffered inside of red cells is through protons binding to deoxyhemoglobin. So H+ likes to bind hemoglobin in environments where there's low oxygen and high CO2. Make sure you understand this. Low oxygen means lots of deoxyhemoglobin, and high CO2 means lots of protons around. That's when you're going to get lots of H+ binding to hemoglobin. And what this does is it converts hemoglobin to the taut form, which releases oxygen. I talk about the taut and relaxed forms in detail in the video on hemoglobin, but conversion to the taut form shifts the oxygen dissociation curve to the right and causes hemoglobin to release more oxygen. And so the Bohr effect is simply a description of this entire phenomenon of deoxyhemoglobin binding protons and releasing more oxygen. And hopefully you can get that this all makes sense. When you've got lots of CO2 around, you're going to produce lots of bicarbonate and acid. And the Bohr effect says that these protons are going to bind to hemoglobin and tell it to release more oxygen, which is going to be needed anywhere that there's lots of CO2 for metabolism. And so on this slide is an oxygen hemoglobin dissociation curve that is shifted to the right from the blue line to the red dotted line. And the Bohr effect simply describes why this shift happens. The high H plus and the high CO2 cause hemoglobin to change its formation and shift to the right. That means that you're going to get more off-2 unloading for any PO2. If you look at the bottom of this slide on the x-axis, for any PO2 level, let's just pick 50 here, you are going to be 50% saturated with hemoglobin on the right curve and 75% saturated on the blue curve. So we have offloaded all this oxygen by shifting from the blue to the red curve. And that is a description of the Bohr effect and why it's beneficial for the release of oxygen. And then the second sort of chemical phenomena you need to understand around carbon dioxide handling is the Haldane effect. So the Haldane effect refers to the observation that oxygen binding to hemoglobin alters the affinity of hemoglobin for carbon dioxide. So low oxygen environments like tissues where oxygen is getting consumed favor the binding of carbon dioxide. And that's a good thing in tissues. When oxygen is being consumed, carbon dioxide is being produced, and you want hemoglobin to bind more carbon dioxide. The reverse is true in a high oxygen environment like the lungs. There, hemoglobin is going to bind less CO2. And this is also a good thing because when you're in the lungs, you want hemoglobin to release carbon dioxide so it can be exhaled from the body. So the Haldane effect was originally described by making observations about how much carbon dioxide is bound to hemoglobin at various levels of PCO2. So as there's more PCO2, in other words, more carbon dioxide present, you're obviously going to get more binding to hemoglobin. But you can see that the two curves here, the slopes are different depending on whether you're in a low oxygen environment like tissues or a high oxygen environment like the lungs. Out in tissues, for any given level of carbon dioxide, you get more binding compared to in the lungs. And that's the Haldane effect. And as we just talked about in the last slide, this is a good thing because it allows more binding of CO2 out in the tissues and more release of CO2 in the lungs. Stated another way, you can think about it like I've summarized in these bullet points here. Deoxyhemoglobin binds more carbon dioxide compared to oxyhemoglobin. And this is a good thing. It allows more CO2 loading when there's oxygen consumption going on in the tissues, and it allows more CO2 unloading when there's a high oxygen environment like in the lungs. So on this slide, I've created a table summarizing all the key things you want to remember about carbon dioxide transport. And what you want to focus on are how things change when blood moves from a high oxygen environment like the lungs and the arteries to a low oxygen environment like the tissues or the veins. So a normal arterial PO2 is about 100, a normal arterial PCO2 is about 40. The PO2 goes way down in venous blood, down to as low as 40, and the PO2 rises to about 45 or 46. A normal bicarbonate is 24, a normal pH is 7.4. The bicarbonate goes up in venous blood and the pH falls, and these are all for reasons we've talked about in the last few slides. You find relatively little deoxyhemoglobin in the arteries, and you find lots of it in the tissues and veins. As we talked about earlier regarding the chloride shift, there's not a lot of chloride inside red cells in the arteries, but there's lots of it in the veins because of the shift. And then the amount of dissolved CO2 is obviously lower in arteries and higher in veins. This is reflected right here by this number for the PCO2. And then lastly, carbaminohemoglobin, which is the hemoglobin bound to carbon dioxide, is obviously relatively lower in arteries, and it's higher in tissue and veins after picking up lots of carbon dioxide from metabolism. And then on this slide, I've placed another table summarizing the differences between tissues where the O2 content is relatively low and lungs where the O2 content is relatively high. I won't go through every row in this table. This is all things we've summarized on the last few slides, but make sure you understand these differences. Okay, for the rest of this video, I'm going to talk about a couple of special situations related to carbon dioxide handling. And the first one we'll talk about is high altitude. So at high altitude, like at the top of this mountain shown here, atmospheric pressure is lower. That means that the partial pressure of oxygen is going to be lower. So when you ascend to high altitude and begin to breathe, you will experience hypoxia because of the lower atmospheric PO2. And the initial response of the body to hypoxia is to hyperventilate to try and bring in more oxygen. So when you hyperventilate, this lowers the carbon dioxide level in the arterial blood. Basically, it creates a respiratory alkalosis, the pH rises, and I talk about all these things in videos in the renal section about how acid-base changes regarding ventilation status. Sometimes this hyperventilation and change in pH of the blood can cause altitude sickness symptoms. So some people, when they ascend to high altitude, develop nausea, headaches, fatigue, and this is all related to changes in carbon dioxide level and pH of the blood. Now, after you've been at high altitude for about 24 to 48 hours, your body will begin to acclimate. And what will happen is the kidneys will start to excrete bicarb, and this is going to bring the pH, which is initially high, back down towards the normal range. And that's where it's going to remain. It will be slightly elevated or at the upper end of normal. And over time at high altitude, there's going to be a chronic increase in ventilation, and that's to make up for the lower PaO2. So I've summarized up here the high yield things to remember about high altitude. There's a lower partial pressure of oxygen initially on ascent. This causes hyperventilation, so the CO2 level falls and the pH rises. But then after 24 to 48 hours, the kidneys begin to compensate by excreting bicarb, and that brings the pH back down closer to the normal range. Okay, let's talk about carbon dioxide and exercise. So when you exercise, you consume more oxygen, and you also perform more cellular metabolism in exercising muscles, so this produces more CO2. In order to blow off that extra CO2, your ventilation rate has to go up. So as you probably know, if you've ever tried to run, your ventilation rate goes up, and it goes up as the body tries to excrete the extra CO2. So with more carbon dioxide produced by muscles, the carbon dioxide levels in venous blood will rise. Make sure you understand this. The muscles are producing CO2, they're putting it into the venous blood, and the venous CO2 level is going up. Your muscles are also consuming more oxygen with exercise, so the oxygen levels in the venous blood will fall. And so if you look at this little cartoon at the bottom of the screen here, which shows an alveolus in the lungs and a pulmonary capillary below the alveolus, venous blood is going to come in, and with exercise, that venous blood is going to have lower oxygen and higher carbon dioxide compared to what you would normally find if you were not exercising. However, because you're hyperventilating, you are going to correct these problems right here in the venous blood. And so arterial blood with exercise should have normal levels of oxygen and normal levels of CO2. They should not change. This is a super high yield thing to understand. Because of the increase in ventilation, these things remain normal in the arterial blood. But they do change with exercise in the venous blood, and that's because of the increase in metabolism. So just to make this very clear, because this is an important point to understand, with exercise, your ventilatory rate goes up, and also your blood flow increases. Because of sympathetic nervous system activation, heart rate and stroke volume go up, and the cardiac output goes up. So all of these things, more blood flow and more ventilation, allow the body to maintain a normal O2 level and a normal CO2 level, despite the fact that more O2 is being consumed by tissues and more CO2 produced. So what you want to remember is what I've summarized here in this box. In the veins with exercise, O2 falls and CO2 rises compared to the levels you would see without exercise. But in the arteries, oxygen levels and carbon dioxide remain normal as long as the person is able to increase their ventilatory rate and blood flow normally. Okay, now let's talk about cerebral blood flow, meaning blood flow to the brain. So it's super high yield to know that cerebral blood flow is controlled by the carbon dioxide level in arterial blood. To understand this, let's look at these two graphs on the screen. So on the left side, we have oxygen content graphed versus cerebral blood flow. And over the normal range of oxygen content that you find in a person throughout the day, oxygen level really doesn't have much effect on cerebral blood flow. It basically stays level. But if you look at the range of CO2 content in blood that you experience throughout the day, you can see that it has a huge impact on cerebral blood flow. As the amount of CO2 goes up, meaning the amount of metabolism goes up, you get more cerebral blood flow. So this is a basic principle of blood flow physiology. CO2 content of blood is what drives cerebral blood flow. And so this has some implications in clinical medicine because changes in carbon dioxide level will change cerebral blood flow. This sometimes becomes important when you have critically ill patients on mechanical ventilation. In a patient on a mechanical ventilator, you can control the carbon dioxide level by modifying the ventilation rate. So if you increase the minute ventilation on a mechanical ventilator, that will lower the CO2 level because there's more ventilation, more CO2 being exhaled. And that's going to decrease blood flow to the brain. And sometimes this is actually helpful in rare patients who have high intracranial pressure, especially if their brain may be about to herniate. Increasing the minute ventilation is an intervention you can do in the ICU to decrease blood flow to the brain, and this is all mediated through changing the carbon dioxide level. Carbon dioxide and cerebral blood flow also play a role in some patients who have panic attacks. So when patients experience overwhelming anxiety, they can develop hyperventilation, and that will lower the carbon dioxide level. And as we've already seen, when you have low carbon dioxide and hypocapnia, that leads to decreased cerebral blood flow and cerebral vasoconstriction. And so in some patients with panic attacks, this can cause central nervous system symptoms like dizziness and blurred vision. And all this ties back to basic physiology about CO2 levels and how that affects cerebral blood flow. Let's talk about carbon dioxide and control of breathing. So you should know that the arterial partial pressure of carbon dioxide is the major stimulus for breathing. There are central chemoreceptors found in the medulla, and these are the most important chemoreceptors for sensing the carbon dioxide level and telling us how fast or slow to breathe. We also have peripheral chemoreceptors outside the brain. You can find these in the carotid and aortic bodies, but these sense oxygen much more than they do carbon dioxide. So these are much more important to responding to hypoxia. They're less important to responding to changes in PaCO2 levels. But the bottom line is through these chemoreceptors, if the PaCO2 level becomes high, the brain will trigger us to increase our respiratory rate. And if the PaCO2 level becomes low, the brain will tell us to decrease our respiratory rate. And that's because these changes in respiratory rate modify the amount of carbon dioxide being excreted by the lungs. So if you know everything I said on the last slide, then it's very easy to understand that the CO2 level is extremely important for determining a patient's ventilation status. If a patient has a high level of arterial carbon dioxide, then by definition, they have hypoventilation. And if they have a low level of carbon dioxide, then by definition, they have hyperventilation. Super high yield thing to understand about pulmonary physiology, how the CO2 level tells you the ventilatory status. And some patients who are hypoventilating for pathologic reasons and develop hypercapnia, they can develop symptoms from high CO2. These are usually nonspecific things like lethargy, confusion, and agitation. But in any patient who has ventilation compromise and lung compromise, if you start to see symptoms like this, you have to begin to wonder whether or not their carbon dioxide level is high. So I'll give you two quick clinical scenarios where carbon dioxide level and ventilatory status are important to understand. The first one is, let's imagine a patient who has neuromuscular disease like ALS, and their oxygen saturation is 95%, but they're receiving oxygen supplementation, maybe through a mask like this man here or a nasal cannula. So because of the oxygen supplementation, their oxygen level is normal, but what's their CO2 doing? Well, if you do an arterial blood gas, their CO2 is 60, which is high. And this tells you the patient must be hypoventilating. And why do patients with neuromuscular disease hypoventilate? That's because their respiratory muscles are failing. So in patients who have advanced neuromuscular disease, they often get a blood gas performed to determine whether or not they have enough respiratory muscle strength to maintain their ventilation. Another clinical scenario that's fairly common is a patient who has pneumonia in the hospital. They're given oxygen supplementation by nasal cannula, so their oxygen level is 95%. But when you do a blood gas, their PaCO2 is 60, which is high. This means that this patient is becoming exhausted. They cannot generate enough respiratory muscle strength to properly ventilate their body, and therefore their CO2 level is rising. They would have low oxygen also, but you're giving them oxygen, so you don't notice the hypoventilation causing hypoxemia. It's only identified by measuring the PaCO2. So once again, these are just two sort of classic scenarios of how the CO2 level identifies hypoventilation, indicating a problem breathing for the patient. Let's talk about oxygen-induced hypercapnia. This is a phenomena that's seen in patients with advanced COPD. So patients with advanced COPD chronically retain CO2. They chronically hypoventilate. They don't have enough lung tissue that's healthy to properly ventilate their lungs. So as a result, they always have a higher than normal level of CO2 in the arterial blood. And what can happen over time is they can lose their sensitivity to carbon dioxide, so that the major stimulus for breathing is their oxygen level, whether it's normal or low. So long ago, it was observed that when you give excess oxygen therapy, like nasal cannula this man is on here, to someone with advanced CO2, they sometimes develop an even higher CO2 level, and this is termed oxygen-induced hypercapnia. So why does this happen? Well, the theory for a long time was that there's a poor response to CO2 in patients with COPD because they've lost their sensitivity. And so when you make their oxygen level high, this causes respiratory depression and worsening hypoventilation. This is probably one component of why this phenomena occurs, but there are newer data that says it's more complex than just this. One of the reasons that's been shown to contribute to oxygen-induced hypercapnia is the Haldane effect, which we talked about earlier. When you administer oxygen, like through nasal cannula shown here, oxyhemoglobin does not bind carbon dioxide as well as deoxyhemoglobin, so more carbon dioxide is released from hemoglobin, and that also raises the carbon dioxide level. So it's probably a combination of effects. I don't think it's critical to know exactly why it happens because that's incompletely understood, but you do need to be aware of this phenomena that occurs in advanced COPD patients. When you give them oxygen, their CO2 level can rise even higher than it is at baseline. And so that brings me to my final slide, where I just want to tell you about the terminology we use around respiratory failure. So there are essentially two ways patients develop respiratory failure. The first is hypoxemic. So in hypoxemic respiratory failure, the PaO2 is less than 60, but the PaCO2 is normal or low. And this is the most common form of respiratory failure. It occurs in lots of lung disorders. You're going to see many, many patients in the hospital with pneumonia and heart failure, and they have hypoxemic respiratory failure. Their PaO2 is low, but their CaO2 is normal or low. It's not elevated. And the reason the CO2 is not elevated is because the low oxygen makes them hyperventilate. And when they hyperventilate, they blow off lots of CO2, and this keeps their CO2 level normal or low. And this form of respiratory failure corrects if you give the patient oxygen. And so this is why many patients in the hospital are on oxygen therapy by nasal cannula or through other delivery devices. A less common form of respiratory failure is hypercapnic. In this form of respiratory failure, the PaCO2 is higher than 50, meaning it's above normal. You can see this together with hypoxemia, especially if the patient's on room air. Although, as we already mentioned a few slides ago, the PaO2 can be normal in hypercapnic respiratory failure if you're giving the patient oxygen supplementation. And the key thing to know about hypercapnic respiratory failure is it always indicates hypoventilation. Remember what I said, a high PaCO2 always means there's hypoventilation. And so this can happen in patients who take too many narcotics, which depresses their respiratory rate. It can happen in neuromuscular disease like ALS, which we talked about before. It can happen in severe COPD from extensive lung damage. And then you can also see this in muscle fatigue from any lung disorder. So a person with pneumonia or heart failure, if they begin to get tired out from breathing so rapidly, they start to hypoventilate, and that can lead to this form of respiratory failure. And importantly, this form of respiratory failure will not get better with simple oxygen therapy. These patients need more ventilation to their lungs, and really the only way to do that is with mechanical ventilation. So hypercapnic respiratory failure is often an indication to intubate a patient and place them on a mechanical ventilator. And that concludes our module on carbon dioxide.